Hello, everyone. Can we hear me? Hello. Okay. Good day, everyone. My name is Dr. Babawali, and this is my first time here. Um, I want to welcome us again to the Concept Academy. I'm one of the clinical tutors. Um, Dr. Festus has been holding forth for me, and I'm sure we have all learned from his wealth of knowledge. Is very legendary. Um, Today, I will be helping us with the dermatological aspects um, of the USMLE. Please, can we all see my screen? Okay.
Yes, we can.
Yeah. So we jump right into it. So I want to assure you all that dermatology is one of the simplest aspects of medicine. And whenever we see any dermatology question in our exam, we should be very, very excited. We are going to go through everything quickly, and we just emphasize on the point we need to take note of, to help us, do very well in dermatology. So we are starting with the skin layers. We are all familiar with the layers of the skin. We have three major layers: the outer epidermis, the middle dermis, and the subcutaneous fat beneath. So three layers: the epidermis, the dermis, and the subcutaneous fat. The subcutaneous fat is also known as the hypodermis, or we can call it the subcutaneous tissue or the subcute layer. Okay. We also need to know the different layers of the epidermis, which is the outermost layer. We need to be familiar with the structure of the epidermis. And the epidermis is divided into 5 layers. We have the stratum corneum, the stratum lucidium, the stratum granulosum, spinosum, and basale. So what we just need to remember is the acronym college. So COLLEGE, just like we can see on my left-hand side. So this will help us remember the first 3 layers. The last two, stratum spinosum, stratum basale, they are not very hard to remember. But sometimes we can confuse the first 3 layers, so which is the stratum corneum, the lucidium, the granulosum. But once you have this word college, it helps you remember it quickly. So the CO is standing for the corneum. The double L is standing for the lucidium. You omit the E, then you are back to the G. So which is the stratum granulosum. Now, what I want to leave you with here is that the stratum lucidium is only present in areas of thick skin. So what do I mean? That is areas like the palm, the sole, where the skin is very thick. So that means you have an extra layer, which is a stratum lucidium. In other part of the skin, the glabrous skin, like maybe the ones in the thigh, the arms, they don't have the stratum lucidium because they are not thick. But for the palms and the sole, you have the stratum lucidium. So the stratum corneum, according to the word college, the L, lucidium, the G, granulosum, the next, which is a spinosum, like spine, and the last one, which is a basale. So interspersed within these layers, you have some cells. So cells like the keratinocytes. So keratinocyte helps us to produce keratin, which gives the skin its tautness, its rigidity, its firmness, and it also prevents desiccation, right? Dryness of the skin. Also, you have the melanocytes. I know we are familiar with these cells. Melanocyte helps to secrete melanin, and melanin helps to impact color to the skin making us black. So people that have too much melanin, they are black. People that have little melanin, they are white, right? We also have some other cells. We have the sweat glands, the sebaceous glands, and other Langerhans cells, which helps in the phagocytosis. All of them, they are submerged within this layer. So we need to be familiar with this layer. It has to be with us spinal level, because there are so many pathological changes that can happen to these layers in different disease conditions that we are going to be looking at shortly. Don't forget that the stratum basale is a one that is most distal, and that is where you have proliferation of most of the cells, like the melanocyte, the keratinocyte, and they ascend upwards to other parts of the cell layer. The dermis have two major components. We have the papillary dermis, which is the one that is superficial, and we have the reticular dermis. So most of the blood vessels, the lymphatics, they are embedded within the dermis. Then beneath the dermis, you have the hypodermis, which is a subcutaneous fat, or what we call the superficial fascia, or what we call the subcutaneous layer. So that one is basically to allow for heat production so that we can feel warm. So having said that, I hope that is clear to every one of us.
Yes.
Okay, thank you. So we move to the epithelial cell junction. So all the skin layer, they are covered by epithelium, the stratified squamous epithelium, which is keratinizing, right? Because we have said that they have keratinocytes, which produce keratin. So that means that the epithelium covering the skin layer is a stratified squamous keratinizing epithelium. These epithelial cells needs to be connected together so that they can be in place, right? And also so that they can perform other functions. And that is what is going to lead us to these junctions. They look complex, but it is very simple. You don't need to stretch yourself. The first we are going to be talking about is what we call the tight junction. The tight junction. You don't need to worry yourself about the other names. They hardly test you on knowing the other names, because it can be controversial. So just stick with the first name, which is a tight junction. So tight, meaning you are connecting two epithelial cells. We can see the one here, and we can see the other one here. Connecting them together tightly. But this connection requires a protein, right? And what is this protein for tight junction? We call them claudins and occludin. Occludins like occlude, close, oppose. So occludin and claudin are the proteins involved in the tight junction, holding the actin microfilament of one epithelial cell to the actin microfilament of another epithelial cell. That is what your tight junction is all about. And what they do is to prevent paracellular movement of solutes. So they don't allow, solutes like glucose, amino acid to be moving uncontrollably. So that is what your tight junction is doing. And the protein involved in mediating that junction is what you call your claudins and your occludins. The next is what you call the adherens junction. Adherens junction. So from the word adherence, you can have an idea of the protein involved. The protein involved here is what you call your cadherin. So an example of a cadherin is what you call the C-cadherin, which is a calcium-dependent adhesion protein. So the calcium-dependent adhesion proteins. Now, what is this one doing? It's also connecting actin filament of one epithelial cell to another actin filament of another epithelial cell. And what is the protein involved? This is not occludin, this is not claudin, but what? Cadherin, which is a calcium-dependent adhesion protein. Now, There's a clinical significance to this protein, and we are going to talk more about it when we start the pathology. I mean, principles of pathology. An example of this cadherin is the E-cadherin. E-cadherin. So E, calcium dependent addition protein. It holds the cell together so that they are in contact with each other. And in this way, it can help to reduce the chance of metastasis. Let me explain. I'll just give you small, background into it. We'll talk more about it when we get to pathology. There's something we call contact inhibition. It has been said that once cells are in contact with each other, when they are in confluence, they have little chance of disseminating and proliferating uncontrollably. But once they are no longer in contact, they start proliferating abnormally. So that is why it has been postulated that one of the major causes of metastasis is what? Loss of contact inhibition. So that means that if an individual has a problem with their E-cadherin, there is not going to be any addition between the epithelial cells again. There's going to be loss of that contact, and there's going to be metastasis. So that is why it is briefly mentioned here that loss of E-cadherin promotes metastasis. You cannot go for your exam and you don't know this. As simple as it is, it can be tested. E-cadherin mutation can cause metastasis. So that means that we can say indirectly that E-cadherin is a tumor suppressor protein. Because once it's there, the cells are attached together and there's no metastasis. But once there's a loss of E-cadherin, the cells are no longer attached, there's loss of contact inhibition, and you have uncontrolled proliferation of the cells. The next is the desmosome. So desmosome is also a form of attachment, just like adherens junction, but the only difference is that desmosome doesn't connect actin to actin. Desmosome, just like adherens junction, also uses your cadherin protein for its attachment, but it doesn't attach actin to actin. It rather attach your keratin to keratin, keratin to keratin. Keratin is an example of an intermediate filament. So your desmosome helps to attach one keratin to another keratin with the aid of your cadherin. Now, what do you call the cadherin here? You call them desmogleins. That's the word. Desmoglein. We have so many of them, but the popular ones that is relevant to us for the sake of our exam is desmoglein 3 and desmoglein 1. You cannot come for dermatology exam and you don't know desmoglein. It is not acceptable. It is not acceptable because there are so many disease conditions that is related to disruption of desmoglein, and we are going to talk about them. So desmosome is attachment using your adherent protein, attaching your intermediate filament, which is what? Keratin, to another keratin. And what is this cadherin that we are using? Desmoglein, just from the word desmosome. Desmoglein 1, desmoglein 3, right? So it provides structural support to the epithelial cells. That protein is attacked in an autoimmune condition that we call pemphigus vulgaris. This might not make sense to us now, but we are going to get there shortly. The next is your gap junction. So gap junctions are very simple. They don't do much. They use a protein too, which you call the connexons, just like we have here, the connexons. And what your gap junction basically do is just to allow for transmission of electrical signals and chemical substances in between the cells, transit of bicarbonate, glucose, electrical potential. That is what your connexon is doing. It is an example of a gap junction. The last is hemidesmosome. So the ones that are very, very important pathologically is the desmosome and hemidesmosome. The hemidesmosome is the last one that is most distal. And what is it doing? Because all the epithelial cells, they must rest on a basement membrane. They have to sit down on something. So they rest on basement membrane. So there needs to be an attachment between that epithelial cells above and the basement membrane beneath. How is this achieved? So that means that we need to form a protein that helps us to attach the keratin filament of the epithelial cells above to the proteins in the basement membrane. And what are the proteins in the basement membrane? Stuff like collagen, laminin, fibronectin. We don't need to cram all these things. It's not going to be tested, but it's good to know it. Just academic stuff. Basement membrane, you have your collagen, your laminin, your fibronectin, and in the epithelial cells, you have your keratin. But there need to be an intermediary that's going to connect your keratin to your laminin, your fibronectin or collagen in your basement membrane. And that is when the integrin come in. So integrin is a modality of attachment between the keratin filament above and your what? Your collagen, your laminin in the extracellular matrix of your basement membrane. Integrin is what is connecting all of them together. And that entire structure is what you call the hemidesmosome. There is a pathology that occurs when there's disruption of this hemidesmosome due to production of autoantibodies. And that is what we call the bullous pemphigoid. We are going to get to it with time. So, is this clear to us? Or there's something that I need to explain again before I move? Anybody?
Can you say that integrin is an example of this hemidesmosome?
Yeah, so the hemidesmosome is a collective name for the entire joining. Do you understand?
Okay.
It's like the collective name for the entire, junction. It's called the hemidesmosome. So, but the protein involved that is attaching the components together is your integrin.
It's okay.
Yeah.
Doc, can you differentiate the keratin in desmosome and the one in hemidesmosome?
They are all the same. They are all
The
the same.
keratin in desmosome connects keratin to keratin, isn't it? The one in hemidesmosome, what does it do?
It connects keratin to collagen, to laminin, to fibronectin. Do you understand? Because the collagen, the laminin, the fibronectin, they are component of the basement membrane here. Do we understand that? So hemidesmosome is just connecting basement membrane to epithelial cell. Desmosome is connecting epithelial cell to epithelial cell. So desmosome connects keratin of one epithelial cell to keratin of another epithelial cell. While your hemidesmosome is the connection between keratin of one epithelial cell and what? Collagen or laminin or fibronectin of the basement membrane. That is it. Very, very important we can picture this in our mind, because by the time we start going through the pathologies, we see the clinical relevance of what we are talking about. So moving on to the exocrine glands. We all know the endocrine glands. These are glands that secrete hormones into the bloodstream directly without passing through ducts. But for the exocrine glands, you need to empty the content through ducts. And we have three types of secretion. Very simple. The merocrine, the apocrine, and the what? The holocrine. So holo, apo, mero. Now, I'm going to start with the holocrine secretion. So when you hear the word holo sounds like oil. Oil, holo, oil, holo, oil, holo, right? So that means that an example of the exocrine gland that's going to be using the holocrine secretion mechanism is something that produce oil. And we can say that the sebaceous gland should pass for that, right? Because sebaceous glands, they produce sebum, and sebum is oily. So holocrine, sebum, sebaceous gland. That is okay. The next one is the apocrine secretion. Apocrine secretion. Apple, like apple. Something that looks like apple. You take a bite from the apple, you know. The mammary gland looks like apple. It has the shape of an apple, right? So we can say that apocrine secretion, you know, can be used by the mammary glands to empty maybe the breast milk or something. They use the apocrine secretion mechanism. Then the last one is the merocrine. Now, let me now explain them one by one, what they entail. Let me go back to the holocrine. We have talked about holocrine, oil. The glands that use the holocrine is going to be stuff like our what? Our sebaceous gland that produce sebum, which is oily. I want us to picture that we have like palm oil, right? In like maybe a bottle. We know that if you are not putting the cold palm oil into the microwave, sometimes you might want to squeeze it, right, out of the bottle into the fry pan. So in the process, you are destroying that cell. So that is a pattern by which sebaceous gland release sebum. Each of the cells containing the sebum, they are being destroyed, they disintegrate in the process of the release into the blood, into the duct. They disintegrate, they are destroyed because you are trying to squeeze your oil from the bottle, right? So they get disintegrated. That is the holocrine approach. For the apocrine secretion, the cells that contains what you want to secrete, breast milk, for example, they don't get disintegrated, but they get pinched off out of the cell into vesicles. Then in that vesicular form, they are now being released into the duct. That is an example of your apocrine secretion. So that's why I give the analogy of apple, being, taking a bite. So taking a pinch of the apple, and apple looks like, the breast rather looks like apple. So you can say that mammary gland, follow the apocrine secretion approach, and the cells containing this secretion, they are being pinched off, to release their content. So holocrine, sebaceous gland, apocrine, mammary gland that looks like apple. An example of another gland that follows the apocrine modality is the apocrine sweat gland. So there are some sweat glands in the body that we call the apocrine sweat gland. And these sweat glands are typically found in areas like the groin and the axilla, because they are being produced in response to changes in age, hormone as we grow, puberty changes, hormonal influence, stress, there's increased secretion, and they can have some smell, especially when you have bacterial acting on them. So apocrine sweat glands. The other sweat glands in our body, aside these two areas, they are called the eccrine sweat glands. So apocrine sweat glands, mammary glands, they follow the apocrine secretion approach. While the other glands in the body you can think of, they will follow the merocrine. The merocrine is a good one that me I like. You are not pinching of anything, you are not disintegrating anything, you are just releasing your content by the process of exocytosis. Very straightforward. Merocrine secretion. So stuff like your pancreatic ducts, your pancreatic secretion, your salivary gland secretion, your eccrine sweat gland secretion, they all follow the merocrine approach. So eccrine sweat gland, that's the gland we see in our thighs, in the legs, the hand, the arm, The apocrine is the one we find in the groin, and the axilla, right? So we know the difference. Eccrine sweat gland, ECC, eccrine, sweat glands, other part of the body. Apocrine, the axilla, the groin. So do we find it a little bit easier using this analogy to, understand the way these exocrine glands work?
Yes, yes.
Okay, that's fine. So moving on to the dermatologic.
Eccrine. You said eccrine. in the book here, I'm looking at 3 of them: merocrine, apocrine, and holocrine.
Yeah.
You said something about eccrine.
Eccrine sweat glands. Eccrine sweat glands.
So eccrine is under merocrine?
Yes, eccrine sweat gland is under merocrine. Why the apocrine sweat gland is under where? Apocrine secretion.
Okay.
That's the way it works. So the dermatologic microscopic terms. So we need to understand these terms to be able to describe dermatologic lesions. And we have a lot of them, about 9 or 10 or so. And I'm going to start with the macule, the papule, the vesicle, and the pustules. The macule, the papule, the vesicle, and the pustule. The macule is the first one. The macule, a macule is being said to be a macule when the lesion you are seeing is a flat lesion that is less than 1 cm. So for example, what we have in image A. Image A is a flat lesion, and you can see that it's very small, less than 1 cm. That is a macule. Now, what happens when this lesion is flat, but is more than 1 cm? You call it another thing entirely. You call it a patch. We can see image B, a patch. It is flat, but it is more than 1 cm. That is a patch. Right? So we go back to the next one, which is a papule. The papule is just like the macule. The only difference is that the papule is not flat. The papule is raised. You can see it is a raised lesion, but it's smaller than 1 cm. So all these ones here, they qualify as papule. Raised lesion less than 1 cm. What happens if this lesion is raised, but is more than 1 cm? We cannot call it a papule again. It cannot be called papule again. We have to call it plaque. Plaque. So plaque are raised lesions more than 1 cm. So what we have here is a plaque. Good. Flat lesion less than 1 cm, macule. Flat lesion more than 1 cm, patch. Raised lesion less than 1 cm, papule. Raised lesion more than 1 cm, plaque. Now, some of these lesions can contain fluid. An example of that is the vesicle. So a vesicular lesion is a raised lesion that contains fluid, but is less than 1 cm. Less than 1 cm. I'm still going to go back to the examples later. I just want to be done with the morphology first. So these are examples of vesicles. You must be able to identify these lesions. Very important. We were able to recognize how a vesicle looks like. You can see that these lesions here are kind of impregnated with some fluid. Very, very important. And it is less than 1 cm. That's why we can call it vesicle. The next here is a lesion that is filled with fluid, but it is more than 1 cm. So this is what we call a bullous lesion. Bullae. You can see that some of them have ruptured. Yeah. You can see this one that is intact. If you are seeing something like this, that has, pathologic significance. Rupture, not rupture. We'll get there shortly. The next is this lesion. We can see this lesion is containing fluid too, but this thing is looking like pus. Once you are seeing pus in the lesion, you know that this is a pustule, pustular lesions. Pustular lesions. This image H is what we call wheal. You see, it's very difficult to describe. You just become used to it. Once you see this image many times, you recognize it. The borders look irregular. And one thing you are going to see in the question stem that is going to help you quickly is that they will tell you that the lesions are transient. They don't stay for long. Max 24 hours. They are gone. Although sometimes you can have them existing for a long time in the chronic form, but most of the time, they are going to tell you that the lesion is transient. And once it looks like this, and it's transient, it's called a wheal. Example of a wheal is urticaria. We are going to get there. We are going to get there. So this is a wheal, transient lesions, that can be, papular, or most of the time they are papular, or plaque sometimes, but they are raised and they are transient. This is what you call scale. So this is more like flaking off of the stratum corneum. Normally the cells within the stratum corneum, they will die and they would present as flakes. You can have some skin disease in which you have excessive proliferation of these keratinocytes within the stratum corneum, and they shed out quickly and they are going to present as scales, right? This one here is what you call a crust. Crust means that you have a lesion, either a bullous lesion, a pustular lesion, a vesicular lesion that ruptures, and the content of that lesion, empties into the overlying skin, and you have the content drying off on the skin. So that's what you call crusting. It means that you have a rupture of a bullous lesion or a pustular lesion, and you have ventral, exudates drying off on that skin. This is very classic for people with impetigo. You cannot miss it. Impetigo. So let us take them one by one again. Quickly, macu. An example of a macu is your freckle, your labia macu. You don't need to worry yourself about that. And when it is more than 1 cm, flat lesion more than 1 cm, call it patch. Example of a patch is vitiligo. You can see this one is, looking like vitiligo, which we are going to explain. A papule is when it is raised but less than 1 cm. Example of that, acne, neurofibroma. Yeah, you're going to see it. When the lesion is raised but more than 1 cm, you call it a plaque. Very good example of a plaque. Psoriasis. You cannot miss it. Psoriasis. Lichen planus. Psoriasis. They are all papulosquamous disorders. The next one is a vesicle. Lesions less than 1 cm containing fluid. Vesicle. A very good example of vesicle is chickenpox. Very good example. Shingles, chickenpox, or varicella, all of them, they form vesicular lesion. Bullae, raised lesion containing fluid for more than 1 cm. Example, bullous pemphigoid. Very important. Pustule containing pus, pustular psoriasis. Chickenpox can also form pustules, depending on how the question comes. So you cannot say that, okay, if I see pustule, it's going to be this. No. Depends on the situation around that particular lesion. And the wheal is a transient, smooth papule or plaque. Example is what we call hives or urticaria. Most of the time they would say urticaria, but it's good you know that they're also called hives, urticaria. They are usually transient. Usually maybe the person used a particular drug or is just allergic to something, insect bites, just have this stuff transiently disappears. Wheal. Then the next is scaly lesions. People with eczema, psoriasis, squamous cell carcinoma of the skin, all of them, they form scales. Then the last is crust, which is the dry exudates. Classic for impetigo. So let us go to the microscopic terms. So we have talked about the ones you see physically, the macroscopic. Moving on to the microscopic terms. So if we observe a lesion on the microscope, what are the potential characteristics that we can see and what do they mean? So the first one is dyskeratosis. So once you say dyskeratosis, what are you talking about? So we mean abnormal premature keratinization. Now, the ideal process is that the keratinocyte should migrate from the stratum basale. As they migrate, they become mature. They start producing keratin. They ascend to the stratum corneum. Once they get to the stratum corneum, they lose their nuclei and they become flat on the skin. That is their life cycle. But in some particular disease condition, you can have that the keratinocytes are migrating from the stratum basale. They are not even completing their maturation process before they start producing keratin. So that keratinization is a premature keratinization. And that is classic for, this keratosis, abnormal, premature keratinization. One leading cause of that is when you have a situation where the cells are proliferating uncontrollably. Example, squamous cell carcinoma. So if there's a cancer, a skin tumor, and they are proliferating abnormally, the squamous cells are proliferating, abnormally, producing a lot of keratin, you can have this keratosis because they are not going to wait till they become mature before they start producing their keratin. An example of another one is what you call hyperkeratosis, and this means increased thickness of the stratum corneum. So the keratinocytes of the stratum corneum are so abundant, they are hyperproliferating, increasing the girth and the thickness of the stratum corneum. That is hyperkeratosis. And that is classic for psoriasis. You cannot forget this. You have to know it. Psoriasis. Psoriasis is associated with hyperkeratosis, increased thickness of the stratum corneum. We are being specific now. The stratum corneum, not the stratum basale, not the stratum spinosum, not the stratum granulosum, but the what? The stratum corneum. That is hyperkeratosis. An example of disease that can be associated with that is psoriasis. Another one is parakeratosis. If you remember, when I was talking about the life cycle, I said the keratinocytes are going to migrate from the stratum basale. They become mature as they are migrating, and they start producing keratin normally. When they get to the stratum corneum, they lose their nuclei and they become flat on the stratum corneum. In some disease condition, these keratinocytes do not lose their nuclei. They retain the nuclei. And an example of such condition is still what you find in psoriasis. So psoriasis, you still find parakeratosis, in which you have retention of the nuclei of the keratinocytes in the stratum corneum. Another disease in which you can have features of parakeratosis is actinic keratosis. We are going to talk about that too towards the end. Hypergranulosis. Now, this is where you have increased thickness of the stratum granulosum. So this one is very straightforward. Increased thickness of the stratum granulosum, you call that hypergranulosis. Increased thickness of the stratum corneum, you call that hyperkeratosis. So the disease condition that is associated with increased thickness of the stratum corneum is what? Psoriasis, hyperkeratosis. For the stratum granulosum, it is what? Lichen planus. Psoriasis and lichen planus, they are brothers. Both of them are classified under the papulosquamous skin problems. But there are some salient differences you must know. Psoriasis is associated with hyperkeratosis and parakeratosis, while lichen planus is associated with what? Proliferation of your stratum granulosum presenting as hypergranulosis. In fact, the stratum corneum, the stratum, spinosum is thin in lichen planus. It is only the granulosum that is thick. Why you have the reverse in psoriasis? The stratum corneum is thick, the stratum spinosum is thick. You have retention of the nuclei of the keratinocytes in the stratum corneum in psoriasis, but the stratum granulosum is thin in psoriasis. Reverse. Moving on to the next, which is spongiosis. So spongiosis just means...
Please, can you repeat what you said about the difference between psoriasis and lichen planus in terms of the layers, please?
So I said that in psoriasis, there is increased thickness of the stratum corneum. That's what you call hyperkeratosis. There's increased thickness of the stratum spinosum, which I'm going to get to, and you call that acanthosis. There is a retention of the nuclei of the keratinocytes in the stratum corneum, and that is what you call parakeratosis. All these things, the three of them, you find it in psoriasis. Why the stratum granulosum is thin in psoriasis? It is not thick, it is thin in psoriasis. Then the reverse is what you have in lichen planus. So the layer that is thin in psoriasis is the one that is thick in lichen planus. So that means that the stratum granulosum is thick in lichen planus, while the other layers are thin. Do you understand that, Doc? Is it clear now?
Yes, thank you very much. Thank you.
So spongiosis is just when you have accumulation of fluid within the intercellular space of the epidermal cells. That's spongiosis. Spongiosis just means you have fluid. You know that when we eat sponge always contains moisture. So it becomes spongy, spongiosis, fluid within the intracellular space. And it's very classic for eczema. So the USMLA like talking about, they like using those terminology, eczema, dermatitis. It also means atopic dermatitis. So somebody having atopic dermatitis, you can also call it eczema, right? Eczema or atopic dermatitis. Atopic dermatitis. We are going to get there shortly. So we have to be familiar with these terms, right? Dermatitis. Yeah. So atopic dermatitis, eczematous dermatitis, they are both associated with spongiosis. Don't forget that. Spongiosis, they hold fluid. Eczematous dermatitis, spongiosis. I'm emphasizing it, is important. The next is acantholysis. So when we say lysis, that means separation. So when you have separation of the epidermal cells, pemphigus vulgaris. Anybody remembers what I said, what we discussed about pemphigus vulgaris? I said it due to problem within one of the junction. Anybody remembers? I don't really expect us to know it now, but I just want to know if we have people actually. Desmosomes. Fantastic. Desmosomes. So there's autoantibodies against your desmoglein 1 and desmoglein 3. And you know that this helps to hold, the keratin filament of one epithelial cell to another keratin filament. So it means that once you cannot hold them together, they will start separating. So that is what we call acantholysis. So they can put in the question stem, describe somebody having pemphigus vulgaris, and the next thing is that what are you going to observe on microscopy? Put spongiosis, hypergranulosis, acantholysis is what you are going to pick. Separation of the epidermal cells. And that's going to bring us to signs like the Nikolsky sign, which we are going to be describing shortly too. Then the last is the acanthosis, not acantholysis. Acanthosis, that means you have hyperplasia of your stratum spinosum, which you see in conditions like acanthosis nigricans, from the name acanthosis nigricans. We are going to see the picture too, and psoriasis, just like I've mentioned. I think I have some questions here. Do I? Yeah, let me just see. I think I have one question here. Okay, let's just quickly look at this. A 23-year-old woman comes to the physician because of a 5-month history of pruritic rash on the cubital fossa of the upper limbs. She has no history of serious illness and she takes no medication. A skin biopsy of the rash shows intraepidermal accumulation of edematous fluid and widening of the intraepithelial spaces between the keratinocytes. Which of the following is the most likely diagnosis? Anybody?
Eczematous dermatitis.
We are already making diagnosis even without even knowing what the eczematous dermatitis is all about. That is it, because we know what you expect on skin biopsy. That's the way it works. So this person is having atopic dermatitis or eczematous dermatitis. So from the presentation and from the histological binding. Okay, so moving on to the pigmented skin disorders. We have level 4 of them. There are actually more than this, but we just talk about them. And the first one here is albinism. Albinism. We all know albinism. We Yorubas, we call them afin. And we need to understand the pathophysiology behind albinism. We should not confuse it with vitiligo. It is very dangerous. USMA they like hiding in that area. It will confuse you with different options, and you should not fall victim for their trap. So albinism is a problem of melanin production. That's it. It is not a problem of melanocyte number. We have the melanocyte in the skin, and the melanocytes produce melanin. You can have a pigmentary problem if there's a problem with the melanocyte number, or if there's a problem with the production of melanin from the melanocytes. But for albinism, it is actually a problem of production of the melanin. The melanocyte number is intact. What can be the reason why this melanin is not being produced? It can either be from the fact that you don't have the enzyme that helps to convert your thyroxine to melanin, which is what? The thyroxinase enzyme. The thyroxinase enzyme. The thyroxinase enzyme. Or there's a problem with the pathways that allow for thyroxine, which is a substrate for thyroxinase, to be transported. Either you are not delivering the raw material, which is thyroxine, or you don't even have the enzyme to catalyze the process, which is thyroxinase. Both of them can, culminate into this condition. Don't forget, the melanocyte number is intact. Don't make that mistake. People with albinism, they have like a generalized hypopigmentation, because if you don't have melanin, the skin is hypopigmented. It looks white, just like image A, right? We have two forms. We have the oculocutaneous form and we have the ocular form. So if we say the ocular form, it means that the problem is confined to the eyes. So they have problems with pigmentation of the iris, problems with pigmentation of retina, and the iris can look blue, can look green, because you cannot impact that color. So that is ocular albinism. And they can have some other eye problems. They are photophobic. They can have strabismus, in which the eyes are not aligning. You just notice that they can be looking at you and you see that the pupil is, the eye is kind of deviated to one side for one eye and the other one is in central. Strabismus. When we come for step 2, we talk more about all those things, but we don't need it for our step 1. Just know that strabismus, one of the features of ocular albinism, and it's a problem of misalignment of the eye. They can have photophobia, just like mentioned. They can have a lot of problems in the eye. They can have nystagmus, so many things. But their skin is okay. For the oculocutaneous, that's the one we commonly see. Their skin is also going to be hypopigmented and it's going to be widespread. It's not going to be patchy. Most of the time it's widespread. The head down, everything hypopigmented. They look white like this person. I see them because of the eye problem. You see them, they squint their eyes. They will be squinting the eyes to be able to see, what they are saying because of the problem with pigmentation in eyes. All of them, they have a very high risk for skin cancer because your melanin helps to absorb your ultraviolet rays, preventing against DNA breakage and eventual mutation. But if you have no melanin, you cannot absorb UVA, you cannot absorb UVB, and all those guys are just there causing problems with DNA. And there's high risk of cancer at the end of the day. I want to leave you with a point, which is, have we done immunology? Has Dr. Babarinde taken us immunology?
No, sir.
Okay, not yet. So we are going to get to the immunological discussion, and I'm just going to mention it. If we forget it, it's fine. But By the time Dr. Professor says it again, it's going to stick, because one thing about learning is that the more the times you hear something, the better it sticks with you. The percentage of people that it's genius, they are like maybe 1 or 2%. Most of other people, they are just, average. You have some super excellent, but genius is not very high. So the more you read something, the more you look at something, the better you are at it. Oculocutaneous albinism is associated with Shideki-Higashi syndrome. You have to know this. Very, very important stuff. So, albinism, they have a milky white hypopigmentation of the skin, the hair, the iris, retina. For the ocular one, they have strabismus, blue-green eyes, photophobia, and nystagmus. The oculocutaneous form of albinism is related to an immunological condition we call Shideki-Higashi syndrome. I know some of us, we have heard of it. And the way we remember Shideki-Higashi is to remember the acronym PLAIN, P-L-A-I-N. The P for peripheral neuropathy. They have tingling sensation in their legs, in their arms. The L for lymphohistiocytosis. So you have abnormal proliferation of the lymphocytes, abnormal proliferation of macrophages, with widespread release of inflammatory cytokines. That's going to be causing like cytokine storm everywhere. The A is standing for the albinism. The I is talking about the recurrent infection, while the N is talking about the neurodegeneration. So that is Shideki-Higashi syndrome. Dr. Babarinde is going to go to town with it, so don't worry about it. But once you see a question talking about features of albinism with problems with infection, you want to think about Shideki-Higashi syndrome. The next is melasma. So I think I have something here. Yeah. So this is a pathway. This is a pathway.
Can you repeat that? You said B-L-A what? I'm sorry.
Plain. I said plain.
Or P-L-A what?
P-L-A-I-N.
O-I-N.
Yeah.
Okay.
Can you see the screen? Can you see the screen?
Yes.
So this is it here.
Okay, right there. Mm-hmm.
Plain.
Okay. Okay.
So I want to show us the pathway, just so that we just are familiar with what I'm talking about. So this is the pathway. We have not done biochemistry, I understand, but phenylalanine goes to thyroxine, and thyroxinase is the enzyme that converts thyroxine to melanin. So if you have problem with thyroxinase, or if an individual have problem with delivery of thyroxine, melanin is going to be produced, and the person is going to experience albinism. So if it's a problem of thyroxinase deficiency, definitely the inheritance pattern is going to be autosomal recessive. The code to figure that out is that once you see a condition in 90% of the situation, please don't quote me. I'm not saying 100%. In like 90%, once it's involving an enzyme, it's going to be autosomal recessive. So if you have that, it can help you figure out some of those inheritance stuff, quickly. The next one is melasma or choloasma. So this one is very common in people that are pregnant, and it's also called mask of pregnancy. Mask. We don't wear mask on the leg. We don't wear mask in the belly. We wear mask on our face. So that means that the lesions particular to melasma or choloasma are present on the face. And what we have here is not hypopigmentation, but rather hyperpigmentation. And it has been postulated that the hormones produced during pregnancy, estrogen, progesterone, or people that use contraceptives like OCPs, these hormones can have stimulatory effects on the melanocytes. They can produce more melanin, and that can lead to hyperpigmentation of the skin, and it's very prominent in sun exposed area. That's why it commonly occurs in the face. So once you see a patient having hyperpigmentation, certainly in the face, maybe after getting pregnant or after using OCP. You know what they are talking about is what? Melasma. You just laugh, you pick your answer, and you move on joyfully. The next is vitiligo. Vitiligo is an autoimmune disease. So that means that we have antibodies destroying something. What are these antibodies destroying? These antibodies are destroying our melanocytes. So that means that the melanocytes are going to be reduced in number. If the melanocyte drops in number, the production of melanin is going to be affected. But what I want you to remember here is that the depigmentation or the hypopigmentation in vitiligo is usually patchy, not like albinism that usually diffuse. Vitiligo is usually patchy. It's very rare for you to see somebody that will have vitiligo from head to toe. No, it's either affecting the head, the face, it's affecting the hands or the legs, which you call the acral distribution. Acral, when you say acral, it means the extremities, acral distribution. Sometimes it can affect mucosal surface like the genitals, the mouth, they can have vitiligo on those areas. So have it at the back of your mind that an individual can develop vitiligo, the extremities, the mucosal surface, and the face, right? And it is due to destruction of the melanocyte by the antibodies. By the antibody. It is autoimmune. And the patch that we are going to be seeing is going to be what? Irregular or patchy. It's not going to be diffuse. We can see some areas of normal skin here. This is the depigmented areas, and we still have normal skin here. So this is classic for vitiligo. Where the USMLE will now come for you is that they can now ask you, what other condition do you think will be associated with this presentation? So you just smile because we know already what they are talking about. Since it is an autoimmune condition, there's a possibility that this individual is going to be having other autoimmune disease. Commonly, type 1 DM. Please don't go and pick type 2 DMO. Type 1 DM is the autoimmune one. Secondly, they can have Hashimoto thyroiditis. Third, they can have pernicious anemia. So just look out for any autoimmune option. You most likely be correct. They can put alopecia areata, something there, anything. But most commonly, it's usually within these three that I've mentioned. Pernicious anemia, pernicious anemia, pernicious anemia, pernicious anemia, Hashimoto thyroiditis, and type 1 DM. Type 1, DM. Very important stuff. Vitiligo. The next is a Waardenburg syndrome. Waardenburg syndrome. And this is what they look like. So people with the Waardenburg syndrome, we don't have an image here, unfortunately, but I have one for us. This is what they look like. And we can see an area of depigmentation of the hair right here. That is what you call poliosis. So you just have this patchy depigmentation of the hair. Poliosis. You notice that their eyes is going to be depigmented as well. The iris is depigmented, heterochromia iridis, and the iris can look bluish, And the most striking presentation is that they are going to have sensorineural deafness. Sensorineural deafness, they will tell you that this individual is deaf. So an individual is having poliosis. You look at the eyes, telling us the eyes is green or the eyes is blue. They're telling us the patient is deaf. They're telling us the patient is having cleft palate or some neurological problems. Just think of Waardenburg syndrome. So I have the acronym PBC. PBC doesn't take care of everything, but at least it's going to help us. The P for the pale hair or the skin, the pale hair or the skin, poliosis. The B for the blue eyes too, as well as the broad nasal root. The C for congenital deafness and cleft palate or cleft lip. Then in addition to that, talk about the neural tube defect or Hirschsprung disease. So the problem here is that you have the failure of the neural crest cells to differentiate into melanocytes. So it's more like a congenital issue. Normally, the neural crest cells should differentiate into melanocytes, and those guys start producing melanin. But because of the failure of that happening, you tend to have some of these manifestations, which includes the poliosis, the blue eyes, the sensorineural deafness, because some of the ossicles also come from the neural crest, so that could be responsible for the and the nerves also that helps in hearing. Come from neural crest migration. So if that fails to happen, the individual can have sensorineural deafness, and they can have cleft palate, although this guy is not having it. They can have neural tube defects, and they can have Hirschsprung disease. Do we have a good understanding of the pigmentary skin disorders now, or there's an area?
I just wanted you to repeat your name, Monique, on the PBC for Wallenberg syndrome.
The PBC is the P for the pale hair. So let me show you. The pale blue eyes, the pale hair and skin. The pale hair and skin, that is a poliosis. You know that if the hair is pale, pigment too cannot form in the iris, so the iris will be blue. Then the B also talks about the blue eyes, in case you don't remember it from the pale blue eyes, so you can blue eyes. The B for the broad nasal roots of the nose. The C talks about the congenital deafness that they have, sensorineural deafness. It's not conductive, sensorineural deafness. And cleft lip or cleft palate, cleft lip or cleft palate. So that's the PBC and the neural tube issues that they can have. Did you get that, Doc?
Thank you.
Okay, so let's look at the question here and see if we can apply some of those things we have learned. Sorry, I want to maximize this. See. A 24-year-old African-American woman delivers a first child at 39 weeks. On examination, the newborn skin and hair have a milky white color. His eyes are light blue with a slight reddish hue. A skin biopsy shows a normal number of epidermal and follicular melanocytes. The physician advised the parent that the child will need a comprehensive eye examination and a genetic testing to establish the suspected diagnosis. A defect in which of the following enzymes is most likely the cause of this patient's condition? Anybody?
Thyroxinase.
Thyroxinase. So this is albinism. Okay. Okay, I think I have only one question there. There's a mistake in the copy. Sorry about that. I thought I had more. Sorry about that. The people, showing us questions, they are going to bombard us with a lot of questions, so don't worry about that. But just don't forget about albinism being associated with reduction in the production. The number is intact. While vitiligo is the autoimmune one that destroys the melanocyte and the number is reduced. So moving on to seborrheic dermatitis. What I just want us to know is the fact that seborrheic dermatitis can occur in children and in adults. That's number one. And number two, the way the lesions appear is that they are going to be described as erythematous plaques. But this is not the major stuff. The major stuff is the presence of this greasy yellow scales, so oily yellow scales. By the time you see that in the description, the number one thing that should come to your mind is that is this person having seborrheic dermatitis? From the word seborrheic, producing sebum. What is the pattern of secretion, from sebaceous gland? Anybody remembers the pattern by which sebaceous gland produce sebum? What is the mechanism of secretion?
Holocrine.
Holocrine. So that sebum is what is impacting these greasy yellow scales in that area. So you're having a plaque, erythematous plaque with greasy yellow scales in area that is rich in sebaceous gland like the scalp, the face, the periocular region. Think about seborrheic dermatitis. Now, the way it is being described is that they will tell you that the lesions affect the nasolabial folds, affect the eyebrow. You can see that there's a pattern. It moves like this, affect this place, goes back to the hair, retroauricular. So retroauricular affect the eyebrows, the nasolabial folds, and also the cheek and the chin. All these areas, they are rich in sebaceous gland. So that is where you have the lesions being deposited in adults. Why in children, they just have this cradle crab. I don't know if you have the image. Oh my God, we don't have the image. I'm going to look for the image. So you just have it at the center of their head. But don't worry about it. You just notice that that head is having some yellowish deposits. So by the time you see that, let me see if I can check one image online. Seborrheic cradle cap. What's happening? Cradle cap. Okay, can we see this? Can we see the image? Hello, everyone.
Yes, sir.
So we can see this yellowish stuff, classic for seborrheic dermatitis. You don't have to struggle with it at all. So once you see that, you have it at the back of your mind that that individual is having seborrheic, dermatitis, as a child. And another fact about seborrheic dermatitis is that once you see it widespread in distribution, think about HIV or Parkinson disease. Rule out HIV, rule out Parkinson disease. Rule out HIV, rule out Parkinson disease. Parkinson disease, HIV, when it is widespread. Do not forget. And what is the problem in seborrheic dermatitis? Colonization with Malassezia species. So that could be Malassezia forfora, Malassezia globosa, anyone they put in the question, but it's going to be Malassezia. It is a fungus that, is a normal flora of the skin. But once you have elaboration of too much seborrhea, it starts, causing all this inflammatory response. It's not actually inflamed. Let me quote myself. The glands are not inflamed, So please don't take that. There's no inflammation. So it's just due to response to this Malassezia stuff that, provokes all this lesion, but there's no inflammation of the gland. And how do you treat? So you apply topical antifungal agents like topical ketoconazole. For children, you apply shampoo. You don't give them antifungal first. You just apply shampoo, containing zinc, parathion, or selenium sulfide, or you can just give them like a wash with emollient application. But in adults, you apply topical antifungal like your ketoconazole cream. If that doesn't work, you can use glucocorticoids too. But most of the time, they don't test beyond that. You just give your ketoconazole for adults. Children apply shampoo containing zinc, parathion, or selenium sulfide, or just wash them with emollient. It's going to go. Don't forget the implicating organism, Malassezia species. Don't forget the description. Grease, yellow, scaly lesions. Very, very important on those particular areas that we have described. Nasolabial fold, eyebrows, retroocular region, with the cheeks and the chin. So this guy now has it on his own, cheeks and the chin. So these are the yellow. It's not very conspicuous, but we get the gist. So moving on to the common ones. The first one we have here is acne. Acne. Acne is very simple. We cannot go for an exam and we don't know what acne is all about. We are just playing. Acne has multifactorial etiology, and it's more like a progression. So acne occurs very common in pubertal, people that are adolescents, blah blah. And because at that age, you have increased elaboration of your androgens. So, and androgens increase sebum production. So you have more sebum being produced. And at the same time, there's also a problem with desquamation of the keratinocyte. So they don't shed out quickly. So you have the keratinocyte proliferating, not shedding, and they kind of clog the pilosebaceous unit. So once we say the pilosebaceous unit, we are talking about we are talking about the air follicles and the pilosebaceous unit. So this is what we are talking about here. So we are talking about the glands, the sebaceous glands, and what? The air follicle. So I'm trying to look for a very good image. Okay, let's just use anyone that we have. Okay, so I can't see the sebaceous gland here. It should be somewhere here, but it's not shown here. Okay. So ideally, you should have your sebaceous gland, surrounding the air follicles here. So the keratinocytes are interspersed here. There's hyperproliferation of those keratinocytes, and not hyperproliferation, sorry, they are proliferating normally, but there's a problem with their shedding. So they don't shed and desquamate properly, and they can occlude this follicle. Coupled with the sebum that you are also producing, all of them, they are occluding the follicle. And when that happens, you are going to have a bacterial ingrowth into that area. And so sorry about this. And the sebum is being produced. There's a problem with the keratinocyte shedding off. That is going to attract the Cutibacterium acnes, and it's going to colonize the pilosebaceous unit because it wants to feed on the sebum. It likes area that is filled with sebum. And when the bacteria thrives on that area, you are going to have an inflammatory response. Now, I want to say something. First of all, there's something we call comedones. Comedones. Let me see if I have an image here. Okay, I don't have an image for comedones. Yeah, so comedones are just like those pilosebaceous units filled with the keratin, filled with the sebum. They present with something like this, and you call it comedones here, like this. Now, you have two types of comedones. You have the white comedone and you have the black comedone. Can we see this tiny spot here? Can we see this? Anybody appreciate this?
Yes.
Yes.
So this is like the black comedone. This is the white comedone. Now, what happens is that once you have the pilosebaceous unit being entirely clogged and is not opened, it's going to form the white comedone. But once it is partially opened, there is an opportunity for air to come in, and you have oxidation. So when you have oxidation of those stuff that are there, they become blackish. So that's why they call black comedones open comedones, and the white comedones are closed comedones. Please, at this point, all what you are just having is lesions formed from occlusion of the pilosebaceous unit, and colonization of your Cutibacterium. But once inflammation sets in, you start having new lesions entirely. And when inflammation occurs, that's when you start forming the pustules. This guy doesn't have much pustules. You start forming the pustules, you start forming the papules, you start forming the node, the nodule. So nodule 2 is a very big, papule. So I don't have an image for nodule here. Cystic acne. Let's just go online. I'm so sorry I don't have image. I thought All these things are here. So nodulocystic acne. So I'm just trying to describe the extent at which the lesion can occur. So we need to understand that. It's very, very important. Very, very important. So can we see this? This is very bad. Can we appreciate all these abnormalities here? We can see nodules here, everywhere, just rough. The treatment approach for this guy now is different from what you do for another person. Now, let me show us also the open and the closed comedones, and so we can see what I'm talking about. So if you see the comedones, think about acne. Yeah, this is a very good one. This is a very good one. No, this exactly. This is what we should talk about. Now we can see the black one. Although we don't have much of the white one present here, but once you just see like we have the white one here. Once you are seeing the white one and you are seeing the dark one, okay, this is comedomal form of acne and it's not very severe, right? So let's go back before I deviate too much. So, do we understand what I'm trying to explain to us? Do we get it?
Yes.
Yes.
So, that is the way it works. But once inflammation occurs in response to that Cutibacterium, then you start having papules being formed. You start having nodules and cysts being formed in the extreme cases. Very important stuff. Very, very important stuff. So that is the etiology of acne. We must be able to connect those four processes: the androgen production, increasing sebum, abnormal shedding of the keratinocytes. The sebum and the keratinocytes, they are occluding the follicles. You have your Cutibacterium going into the follicles, and you have formation of the comedones, depending if it's open or closed. Then subsequently, you have inflammation that leads to, development of the papules, the pustules, the nodules, the cysts. How do you treat? So if this person is just having comedomal stuff, you can give your retinoids, stuff like tazarotene or adapalene. I have it here. Adapalene, and tazarotene. All these guys are containing vitamin A, like the vitamin A derivatives. And I'm sure we have done neurology. Have we done neurology?
That's what we're doing currently.
Okay. I would have loved to try that question so that will give people opportunity to shine. But do we know has Dr. Fessos mentioned anything about vitamin A toxicity, obesity, causing something, giving risk factor for something?
He hasn't mentioned it. We haven't reached there.
Pseudotumor cerebri.
Exactly. So idiopathic intracranial, hypertension. So pseudotumor cerebri. So people taking this retinoid, you have to be careful, because they are vitamin A derivative and they can cause pseudotumor cerebri. So you don't want to be combining with things like tetracycline or other things that can, elevate that pressure. So you start with your retinoids. You can also give benzoyl peroxide. They are all comedolytic and they can reduce the inflammation too. And if that doesn't work, you can add antibiotics, particularly clindamycin, erythromycin, clindamycin, erythromycin, they are used as antibiotics. So after you have started with your retinoids, you've maybe plus or minus your benzoyl peroxide. That doesn't work, you can add antibiotic. But if an individual that you are seeing for the first time is having nodulocystic acne, that is not the time to be giving retinoids or benzoyl peroxide. You're just wasting your time. At that stage, you need to place that person on isotretinoin. But isotretinoin is a very powerful drug, and the first thing you need to do is to rule out pregnancy. Do HCG test to rule out pregnancy because it is teratogenic. So rule out pregnancy. If you have confirmed that, okay, this person is not pregnant and the person can use the isotretinoin, you are going to offer the person two different modes of contraception. That is You either place the person on COCPs and you tell the person that you have to use a barrier method or you get an IUD. Just make sure that the person is on at least 2 contraception that works via different mechanism. Then you now place the person on the isotretinoin. It is that what I've just described can be tested anyhow in the USMLE. It is the understanding that is important. Very, very important stuff. Don't forget, nodulocystic acne is a very severe form of acne, and you need to place the person on isotretinoin, oral isotretinoin. Moving on to, and this is the way acne looks like, we have seen that. Moving on to the next one, which is atopic dermatitis, also known as the eczema, just like we've talked about. And the microscopic feature of eczema is what? Spongiosis. What do you see that's going to raise your suspicion for atopic dermatitis? It depends on the age of that patient. It depends on the age. If the person is an infant, less than 2 years, so the lesion typically starts on the face. This is what you are going to see in the question term. They will tell you that the child is having a pruritic lesion on the face. Please, that is not the time to be thinking about slap cheek or something, because I know some of us are familiar with slap cheek rash. Pruritic lesion on the face. You want to calm down. Is it parvo? Is it atopic dermatitis? But if it's pruritic, it's likely to be atopic dermatitis. The guy is always scratching it. And they can also tell us that the rash is also involving the extensor surface of the extremities, particularly the elbow. That is in keeping with the infantile form of atopic dermatitis. Very important stuff. Very, very important. Very, very important. But once the child grows beyond 2 years, the distribution of the rash changes. It changes totally. It moves from the face, it leaves the extensor surface, and it comes to the, what's called? It comes to the flexor surface of the extremity, like the cubital fossa of the elbow. So it comes anteriorly, and it's very, very pruritic. In fact, some of them can have it lichenified. So lichenified means that they have scratched it such that the skin is now dark and thickened. That's lichenification. So if that is described in the question stem, you know that they're talking about a very severely pruritic lesion like atopic dermatitis. You have seen all these things, but what else do you need to further consolidate your diagnosis? You have to look out for history of atopic disease. They can tell you that there's a family history of asthma. They can tell you that the family history of allergic rhinitis, always scratching the nose, always sneezing. They can tell you that the child reacts to some certain food. When the child takes crab or takes seafood or takes, shawarma or something, he starts having problems. Food allergy. Classic for people with atopic dermatitis. If you do a blood work, you can see, elevation of your IgE level, which also is a pointer to the atopic involvement. And don't forget the distribution of rash in children less than 2 years, the cheeks, extensor surface, more than 2 years, children more than 2 years, and adults, you see it in the flexural surface, and it is lichenified most of the time. Don't forget that it is associated with other atopic disease, so that will further strengthen your diagnosis. And it can be associated with some other similar diseases like ichthyosis vulgaris. Now, the reason why this is being mentioned is because the pathophysiology of atopic dermatitis is believed to be associated with mutation in a gene called filaggrin. Filaggrin is like a protein that constitutes part of our epithelial barrier. And once we have our filaggrin, we don't have water escaping from our skin abnormally. So, and the barrier, the epidermis too is intact and is not permeable to entry from microbes, and all those things. In people with atopic dermatitis, they have problem with filaggrin. So water escapes. And when water escapes, the skin becomes dry. That's number one. Number two is that you can allow for entry of microbes. The inflammatory response to the microbes allows for development of the lesion. So that is how filaggrin causes a problem in atopic dermatitis. Filaggrin is also mutated or is also having problems in people with ichthyosis vulgaris. So keep that at the back of your mind. Very important stuff. Do I have any question here about all these things? Yeah, I do. Okay. I don't know what I have here. Okay. Let's move. Once we are done with everything, we look at the questions. So the next is allergic contact dermatitis. So once we say contact dermatitis, they are saying that, no, sorry, before I leave, the rash associated with atopic dermatitis is usually vesicular, papular lesions. So papulovesicular lesions. That's very important stuff. Vesiculo. But if there's somewhere we jot all these things, we can take note of it. So you see vesicles, you see papules in the area of distribution that I have talked about. Don't forget. Sometimes they can tell us that the lesions are weeping. They like saying that term a lot in the question. So weeping lesions, it means you're having vesicular lesions that is like, oozing out fluid because they contain fluid. So they will be oozing. So they are called weeping lesions. Once we are seeing that, puritic lesion, dry lesions, this is atopic dermatitis until otherwise proven. Allergic contact dermatitis. So the word contact dermatitis means that there is a particular agent that is in contact with our skin that is inducing the lesion. What the question is going to tell you is that so individual started noticing the lesion after wearing a gold chain. The person noticed the lesion after washing as a dry cleaner somewhere. The person noticed the lesion after wearing a particular jewelry. You know that is likely to be contact dermatitis. It's because that particular stuff is in contact with the skin. That is why the lesion is manifested. Now, what are the possible types of contact dermatitis? What we have in our book is one type, allergic, but I want to tell us that there's another type, which is the irritant contact dermatitis, but we are going to talk about the allergic here. And I want to also tell us that the allergic contact dermatitis is a type 4 hypersensitivity. That means that your B cells, your immunoglobulins have no role here. Your neutrophils, they have no role here. The only cell that is involved in type 4 hypersensitivity, anybody knows? What is the only cell involved in type 4 hypersensitivity? Anybody knows?
T cells.
T cells.
The T cells. The T cells. The T cells. That's what you are looking for. The T cells. Type 4 hypersensitivity. How does it happen? Little short background. The person get exposed to the allergen. What are these allergens? It could be jewelry containing nickel, gold chain, all these rings, I don't know, watch, all those things, belts. Some of them can contain nickel, right? It could be perfume, deodorant, spray it to the armpit, the neck, all those things. It could be plants. So there's some plants that contain a particular allergen that I call urushiol. So there's something you call urushiol, and urushiol. And you call that the poison ivy. They can call it the poison ivy. They can call it this poison sumac. Or they mean the same thing. They are the same plants. So poison ivy, poison sumac, they are plants that they release a particular toxin, a fluid that contains urushiol. So this urushiol is an allergen. When it's in contact with the skin, it can trigger allergic contact dermatitis. Some people can use some antibiotics, topical neomycin. They apply it as cream to their body. It can be a potential allergen. Some people can use some particular cosmetics, put foundation on the eyelids, the face, all these things, potential allergen. What happens? The first time is going to be the process of sensitization. That is, your Langerhans cells of your skin, you know, this might not, we are still going to do immunology, and Dr. Obarinde is going to make it make very good sense. Once you have your allergy being introduced at first, the Langerhans cells are going to pick those allergen and they are going to take it to the lymph node that, Oga, this is another stuff I'm just seeing for the first time. I don't know what it is. What's in this thing? They present it to the lymph nodes, and the lymph nodes are going to, you know, release of cytokine that is going to differentiate the T cells into a particular committed pathway, getting ready for the next time those allergen comes. So they'll be like, okay, we go give them first warning. Let's wait. If the person comes again, we are going to attack. So that is sensitization. So the next time the person get exposed to that allergen again, then your inflammatory response is provoked. You already have your T cells that will recognize that antigen standby. So by the time they come in again, they start mounting attack on them, and you start having so many lesions being produced. So, and it usually occur like 4 to like 10 hours after the second insult, you start having the lesion. So that is your allergic contact dermatitis. Your allergic contact dermatitis. So the allergic there, in a way, is a misnomer, because it doesn't involve type 1 hypersensitivity. If it's type 1, then we can say that allergic, yeah. So don't get confused. It is allergic contact dermatitis, but it's type 4 because it is only the T cells that are attacking. And it can come from nickel, your poison ivy, which contains uroshiol, and they are plants. They are plants. So when somebody goes hiking, they go for maybe mountaineering, and they get exposed to some of those plants, they'll just tell you that there's a linear lesion, you know, in their extremity, which occur a few hours after going hiking. You know, it's likely to be that this person has been exposed to poison ivy, causing allergic contact dermatitis. Neomycin is a potential cause too, cosmetic, and that potential cause. So let me see. That about contact dermatitis. You also see lesions very similar to atopic dermatitis. You can see papules, you can see vesicle, but what is going to differentiate them is that they are going to have a specific distribution. Either it's affecting the left part of the left arm, you know, or part of the neck, or part of the wrist, depending on where that allergen is. For irritant contact dermatitis, you don't need any hypersensitivity. The problem there is that the particular agent that you are getting in contact with is what is causing a direct cytopathic effect on the skin. For example, people that wash plates, some of the detergents can irritate the skin and cause irritant contact dermatitis. It could be metals, it could be alkali, it could be base, it could be acid, soap, anything. That's irritant contact dermatitis. So they do that in time to time, and with time it's going to start, you know, irritating the skin, and they are going to start having those lesions. So there's no image for, I don't think there's so this is a very good image. What are we going to think of to be the allergen in this image D? Anybody?
The belt.
The belt. So
Yeah.
there's the release of nickel from the belt. You can see that it's localized allergic contact dermatitis. Okay. The next one is the keratosis pilaris. So this one is not well tested, but what is just happening here is you just have increased production of keratin. They are occluding the follicles, and from there you have the lesions being developed. So they are very common in the extensor surface of the limbs. So you have like small papules in the extensor surface. So if you have somebody having small papules in the extensor surface that is not very puritic, and you are not seeing family history of any allergy, blah blah, you can consider keratosis pilaris as your diagnosis. It's not very common. It's not very common. So don't forget, it's just due to occlusion of the follicles by keratin, and it's present in the extensor surface of the arms and thighs. If it was atopic dermatitis in an adult, you don't expect it to be on the extensor surface. You expect it to be on the flexor surface of the arms and the thigh. Melanocytic nevus, so people that want to get the 250s, the 260s, these are the questions that they palm. So everybody knows allergic dermatitis and all those things, but Stuff like melanocytic, many people don't pay attention to it. And it's also called the common mole, the mole. So you can have, it's benign, it's more like benign proliferation of your melanocytes. If it's malignant, it's already a melanoma, right? So you have the acquired type and the congenital type. So you have some people that they are born with this melanocytic nevus, this benign proliferation of your melanocytes, congenital. And you also have what we call atypical moles. So atypical moles just means some moles that look like melanoma, but they are not melanoma. They don't meet all the requirements of melanoma. And by the time you do your biopsy, you don't see features suggestive of melanoma in them. When we get to melanoma, I'm going to shed more light on that. So melanoma can actually develop from atypical moles. It can also develop from congenital moles. So moving on to the acquired moles. So there are 3 types of acquired moles: the intradermal nevus or the intradermal mole, the junctional mole, and the compound mole. So we have intradermal here. We have intradermal here. We have junctional here, but we don't have the compound. So I'm going to tell us what it is all about. Now, we start with the junctional mole or the junctional nevi. It is a form of acquired nevi. And what do you see in the question that is going to raise your suspicion for this? It is a flat macule. That's what you need. That's all. Once you see like a mole that is a flat macule, that is basically your junctional mole. So this is an example. You can see this mole. This thing looks black, dark. This is how the moles typically look like. We remember that moles are benign proliferation of what? Benign proliferation of melanocyte. And if melanocytes are hyperproliferating, what color do we think they are going to impact?
Hyperpigmentation.
Hyperpigmentation.
Black.
Exactly. So this guy is looking brownish, blackish. So we know that, okay, something happened to the melanocyte here. Mole. And it is flat. This is junctional mole. So that means that you are having like hyperproliferation of the melanocyte at the junction between the dermis and the epidermis. So by the time you do histological biopsy, that is what you are going to see for the junctional mole. That's why they call it junctional mole. Hyperproliferation between the junction of the dermis and the epidermis. And don't forget, grossly or macroscopically, they are flat lesions. Moving on to the next one, which is what? The compound mole. So the compound mole or the compound nevi, they are not flat. They are raised, just like the one we have here. So this one is an example of maybe a compound mole or intradermal. Both of them are raised. But how you are going to differentiate compound mole from intradermal mole is that in compound mole, you have proliferation at the junction between the dermis and the epidermis, and at the same time, it also extends to the dermis. That's why I call it compound. It's taking 2 things. Choose a struggle. Are you staying in the epidermis or you are staying in the dermis? So it wants to stay in both epidermis and dermis. So staying at the junction and also extending to the dermis. That is your compound mole. And it is raised. But if the question tells us that you're having a uniform, well-circumscribed lesion just like this, which is brown or dark, raised, and they do the biopsy, they notice that the proliferation is confined to the dermis only. So we are going to call that a what? Intradermal nevus or intradermal mole. Can we differentiate between the 3 now? Does it make sense to us? Anybody? Huh?
Yes. Can you run it down again, please? I'm sorry. Especially the compound and the intradermal. Is it the next one, isn't it?
So the compound mole is raised. The intradermal mole is raised. But the difference is that both of them are papular. They are raised. The difference is that if you do your biopsy histologically, your compound stays at the junction between epidermis and dermis, and at the same time, it extends to the dermis. Do you understand that, Doc? Do you
Yes,
get that?
yes,
Why
I
for
do.
why for the intradermal, it does not involve the junction at all. It is only in the dermis.
Okay, thank you.
That's it. So the next one is the pseudo folliculitis Babi. So this one is very easy. This is bonus question. Once you see this, is bonus. It just means that the individual is having some very painful pruritic papules or pustules along the jaw, the chin, due to the way they are shaving. Let me show us what they look like. So, wow, we used to, they have made so many changes to this edition of, there used to be a very good picture of pseudofolliculitis Babe in our previous one. Pseudofolliculitis Babe. So you are going to see something like this. Is a very brilliant example. So once you see this, these are like papules. You can see the papules everywhere. So in the jaw. So it is very pruritic. They're always scratching it, and it's painful. And the problem here is that it's very common in people that are black, people with curly hair, such that when they shave, the follicles of the hair that is remaining grows inward, like it curls backwards into the skin and irritates that skin. So that is a problem in people with pseudofolliculitis Babe. It's because they have a curly hair that grows back inwards to cause irritation of the skin with eventual inflammatory response. So it's characterized by erythematous papules and pustules. No comedones. So no comedones means they have ruled out what? Anybody?
Okay.
They have ruled out acne. They have ruled out
Mm.
acne. Sorry, there's something else you are talking about too. I'm reading another thing entirely. So it has firm papules and pustules. So it's very coincidental. That one's true as papules and pustules. Yeah. So it has firm papules and pustules that are painful, and it is non-puritic. So it occurs near the joint, just like we have said, as a result of shaving. So what do? You just tell them to stop shaving for at least 8 weeks. So they tell them to stop shaving for at least 8 weeks, and the dermatologist is going to train them on how to shave properly to prevent, the skin from coiling back to irritate the skin. So very common in people with naturally curly hair and people that are black. So don't forget pseudofolliculitis Babe. The next is psoriasis. Psoriasis is high yield. Very, 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 like extremely important. Very, very high yield. So what is psoriasis? Psoriasis is one of those papulosquamous disorders in which you are going to see papules and plaque. And what is this? What is the peculiarity about these papules and plaque? The papule and plaque that we are talking about, they are going to appear scaly. Scaly in terms of the fact that they have what we call a slippery, whitish scale. Just like what you can see here. Can we see this whitish blah that is surrounding this thing? And we can see that this is a plaque, right? We can call this plaque, right? We can see that it's raised and it is more than 1 cm. This is psoriasis. Now, why am I confident that this is psoriasis? Number one, I can see the plaque. I can see the white silvery scales. I can also see that it is affecting the extensor surface of the extremity. I am sure that this is psoriasis. Now, what other test am I going to do to be sure that this is psoriasis? I am going to scrape off some of these scales. And if I scrape off the scales, I'm going to expose the dermal papillae. They are just like tiny microvessels, which are going to be bleeding, just like what we have done in image high. You can see the tiny bleeding point. That is what we call the Auspitz sign. Auspitz sign. Dermatology is full of so many signs. We have to be familiar with all those things. So by the time you scrape off the scales, you expose the underlying dermal papillae, and there's going to be multiple bleeding points. We call the Auspitz sign. So they describe that in the question stem. think about psoriasis. Who wants to tell us the histological finding in psoriasis? So what are the 3 histological findings that we expect? Anybody?
Hyperkeratosis, parakeratosis, and acanthosis.
Thank you. Thank you. So para meaning retention of the nucleus, hyperkeratosis meaning thickening of the stratum corneum, and the acanthosis meaning proliferation of the stratum spinosum. The auspice sign is another one. There's another thing again they can put in the question that is not in this book that I call the Koebner phenomenon. And what they are trying to say there is that if I go to this normal area of skin and I strike that area, I inflict trauma, these lesions are going to appear. With time, they are going to appear. That is the Koebner phenomenon. You can find that in people with psoriasis. Now, let me go back so that I don't miss anything. There's another thing you call the micro abscess of Monro. So the Monro micro abscess, it means that you have migration of neutrophils from wherever part of the skin to the stratum corneum. So by the time you do your histological analysis, you are going to be seeing tiny, tiny neutrophils at the stratum corneum. That is classic for psoriasis, and you call that the Monro micro abscess. We can see the acanthosis we have mentioned. We can see the parakeratotic scaling. We can see the Monro micro abscess. We can see some of the histologic changes, which is increase in the stratum spinosum, which is in keeping with the acanthosis. We can see a drop in the stratum granulosum, which is the reverse of which condition? Anybody?
Lichen planus.
Lichen planus. Yeah. And the auspid sign, which is what? The pinpoint bleeding point from exposure of the derma papillae when you scrape off the scales. What is the joker that you must always know for psoriasis? That is the joker that they might want to use, to get people. And that's the fact that psoriasis is associated with nail pitting. Psoriasis is associated with nail pitting. Psoriasis is associated with formation of oil spots. Psoriasis can cause psoriatic arthritis. Now, I know that Dr. Babarinde have taught us about the seronegative spondyloarthritis, right? Have we done it?
Yes.
Yes.
So what are the seronegative spondyloarthritis?
Yeah.
The pear. So what is the P? What is the P?
Psoriatic arthritis.
Psoriatic arthritis. What is the A?
Ankylosing spondylitis.
Ankylosing spondylitis.
Ankylosing spondylitis. What is the high?
IBD.
IBD.
Irritable bowel syndrome.
Exactly. What is the R? What is the R?
Reactive arthritis.
So all these conditions have rheumatoid factor being positive in them, right?
No, negative.
I thought somebody is going to fall for the trap. They don't have rheumatoid factor. So you have to have that at the back of your mind. So somebody with psoriasis can have psoriatic arthritis. That's going to be, seronegative. And you can see some deformities in the distal or the proximal interphalangeal joint. You can see the swan neck deformity. We can check out all these images online later. You see the nail pitting. You see the oil spot. So I don't know. I'm not sure we have any image of the nails here. We don't have it, unfortunately. You just see that the nails are pitted and you see some oily areas in the nail. That's oil spot. All of them, they're in classic for psoriasis. By the time you come for step 2, then we dilate more on this. You talk about the treatment because anybody with psoriatic arthritis, you don't give that person vitamin A or vitamin D. You give the person DMARD straight. The person is going to be on DMARD because that's a very severe form of psoriasis. But for the sake of our step 1, I don't really think we need to worry about the treatment, but I'm going to mention it because nobody knows what can happen. So for psoriasis, the normal one, you just want to place the person on vitamin A or vitamin D analogs. So I mentioned some of the vitamin A analogs when I was talking about treatment of acne. And that's like your tazarotene, your adapalene, right? The vitamin D will include stuff like calcipoterine. We should not really worry much about all these things. Vitamin D analog works for psoriasis. But when an individual develops psoriatic arthritis, immediately you place on DMARD, your methotrexate, your TNF antagonist, and the likes. So that is that about psoriasis. Don't forget about the description. Sometimes the question can tell you that the scale, they are micaceous. So they can use the word micaceous. So it means silver too. Micaceous scaling. Once you see this, that is silvery scaling. Very common in psoriatic arthritis, psoriasis, stuff. The lesions are extensor. The knees and where? The elbow. The knees and the elbow. Please, don't say that the knee is in front too. That is not extensor. Anything in front in the legs, it is extensor. Anything at the back for the upper extremity, it is extensor. So elbows is extensor in upper extremity. Knees is extensor in lower extremity. So the popliteal fossa is going to be what position? Anybody knows? Popliteal fossa.
Flexor. Flexor.
Thank you.
Flexor.
So popliteal fossa is going to be flexor. So if an individual develops papulovesicular lesion at age 10, which is pruritic in the popliteal fossa, what is going to be our diagnosis? Anybody?
Atopic dermatitis.
Oh my God, these doctors are good. That is the way it works. Very simple and basic. So moving on to rosacea, very commonly tested. Step 1, step 2, you have to know it. In fact, in step 2, it is a very serious matter. And what basically happens in rosacea is that you have an inflammation of the skin, and usually they have erythematous papules and pustules, and they, just like they have there, said there's no comedone because it's not acne. It looks like acne, but it's not acne. So that's why they put it here that you will not find comedones. What you need to hold on, is the trigger. Most of the time, they will tell you that the person has taken alcohol, the person has been exposed to sun, the person has done strenuous, intensive exercise, the person has taken hot, spicy food, or the person had a hot beer or something, which is going to cause flushing of this face. By the time you see flushing with widespread erythroderma of the face and some tiny papules and, papules on the face, think of rosacea. So this person has been on the sun for a long time, done exercise for a long time, taking alcohol, spicy drink, spicy food. This is rosacea we are talking about. So we have different form. We have the erythemotelangiectatic type. So what they are talking about here, forget about the big name. What they are just saying is that you have widespread erythema of the face with telangiectasia. So we know what telangiectasia looks like. So once you are seeing like that spider web, that spider dilatation of the vessels with erythema of the face, that's the erythemotelangiectatic type. They can tell you that the only thing we are seeing there is just flushing and papules and pustule. That's the papulopustular type. They can tell you that what we are seeing there is just bulbous dilatation of this nose. We can look at this person's nose. We see that this nose is not normal. This nose is not a normal nose. This nose is big. So this is like what you call rhinophema. So bulbous dilatation of the nose is another feature of rosacea. And the last type is the ocular type. So it just tells us that the eye is having some issues, redness of the eye, some secretions in the eye, but that's like for step 2. But I'm just mentioning it, the papulopustular type, the erythemotelangiectatic type, and the rhinophema. So complications include ocular involvement, so it can involve the eye, in which we are having redness of the eye, ocular problems, problem with the acuity, everything like that. And they can also have rhinophema, which is bulbous deformation of the nose. The nose is going to be big. For step 2, the approach to treating is different. Step 1 will not ask you for the treatment. They will just ask you either for the pathophysiology or like what is involved or like the diagnosis. That is what you need to know. So let me show us another picture of rosacea because I don't want us to miss it. It's very high yield, It's commonly tested. We need to know, you know, what it looks like. Most of the time, you just see the nose extraordinarily big. The nose is just, you know, and you'll be wondering what's going on here. So, and of course, the flushing of the face. So look at this man now. Look at this man now. This man is likely having, you know, probably maybe the papulopustular type. You know, you can see the flushing of the face. You can see the papules. You know, the nose too a little bit enlarged. You know, sometimes it can be deformed. I'm not seeing anyone that's actually spoiling the nose. This guy's nose is already getting there. You know, but that is what you expect. So don't forget about that. The triggers: sunlight, alcohol, spicy food, exercise, all those things. So just avoid the triggers. Avoid the triggers. Step one. So let's go back. That's all about rosacea. The next is seborrheic keratosis. Seborrheic keratosis. Seborrheic keratosis. So seborrheic keratosis, don't confuse it with seborrheic dermatitis. They are different things. And what I want us to hold for seborrheic dermatitis is that for seborrheic keratosis is that it is actually the commonest benign skin tumor. It is a tumor. It is the commonest benign skin tumor in individuals more than 30 years. What are we going to see? That is dermatology. You need to know what you are going to see. What you are going to see is a well-circumscribed lesion that is hyperpigmented, giving a stock-on appearance. So when you see this stock-on appearance, you can see it in question. What it means is that it's like you have like a button, you put it in like a clipper or something, and you press it to the skin. You know, when you imprint something to the skin, that's what it means stock on you. It's like you attach it. It's like it's not part of the skin. It's like it is attached to the skin. If you look at this thing, it looks like it's something that we attach and we can remove. Stock on appearance. And it is due to a benign proliferation of, you know, the cells within the skin. And, you know, it's very common in areas where you have, you know, seborrhea too, like, you know, like the face, the chest, and the area like that. And one thing again you are going to see is that you are going to see what you call the oncyst. So they're like hyperproliferation of your keratinocytes. Hyperproliferation of your melanocytes, which are impregnated with keratin. So this here now is an on-field cyst, something like this. You know, all this tiny stuff here. You know, don't forget the fact that it is well circumscribed, it is well demarcated, it is hyperpigmented. You can have the, you know, keratin filled cyst impregnated on it. It is a tumor, and sometimes it can be very naughty, especially in conditions where you have numerous amounts of these lesions, particularly at the back. So it's very, very important you're able to recognize that. Once you see a lot of seborrheic keratosis at somebody's back, that is a paraneoplastic manifestation of a malignancy. So you want to rule out, does this person have a gastric adenocarcinoma? Commonly tested. What do you want to screen for? Somebody with multiple seborrheic keratosis at their back. It's likely to be that they have an underlying gastrointestinal tumor. Very important. So it's due to, so sorry about that. I made a mistake. It's due to hyperproliferation of the immature keratinocyte, not melanocyte, please. And they are filled with keratin. So it appears stuck on, just like we can see here, right? And when it is multiple, you call it the lesser Trellat sign. The lesser Trellat sign. The lesser Trellat sign. You know, rapid onset of multiple seborrheic keratosis, which indicates a possible malignancy, like a GI adenocarcinoma. Please take note of the nomenclature of the cancer. It is not GI lymphoma. It is not GI, you know, stroma tumor. It is GI adenocarcinoma. Very, very important stuff. When it is multiple, it is a tumor of the keratinocyte, the hyperproliferating. Sometimes they can fill with some secretions, forming the horn cyst, and where there are multiple, you think of a GI malignancy because of the lesser Trellat sign. The verrucae, we are very familiar with verrucae. They are also known as warts, warts. So they are like cauliflower-like papules. They can occur in every part of the body. They can occur in fingers, so many area. And it is caused by HPV virus.